I know you've had Dr. Boko last time. I don't know, that was on endocrine disorders, so I don't know how many of y'all were able to sit in on that. And Dr. Bogano before that. And Dr. Bogano is an oral medicine specialist, a little bit different from oral pathology. We're a little bit more bench oriented, and oral medicine is more internal medicine, if you will, in dentistry. But we do have some overlap, and I still see patients in our urgent care clinic, and so hopefully this will be somewhat meaningful to you. I do obviously realize that y'all have a much better handle on the majority of this as far as diagnosis, classification, management, and all that. But kind of what I wanted to do today was pretty much hit on four things. One of them will be potential medical problems that we see when we're trying to see a patient that has some disorders. We want to look at oral manifestations of some of these disorders, the prevention of problems, which, there can be significant problems with these patients dentally, and then treatment planning modifications that we might have to do when we see them in the dental chair. Some of these will apply across the board. Some of them will change a little bit if we're seeing a patient on an urgent basis, or even differently if they're on an emergent basis. The difference being a lot of times, we have urgent cases if somebody has a toothache, where we might not call it an emergency. Emergency would be if they have an acute infection, facial trauma, stuff like that, and they would be seen in the OR probably. Anyway, in doing a little background reading, since putting this together, the authors wanted to say that most of their information was based, I guess, on the 4th edition of the Diagnostic and Statistical Manual of Mental Disorders. So if some of this is out of date, I apologize. I think most of it will still apply. Another thing is I kind of like to go off on rabbit trails. And please stop me if I go too far off, or if you have questions on things, we might talk about an aphthous ulcer and go too long on that, and stuff that you might see in your practice that you'll be comfortable handling, or maybe you want to contact one of us, or maybe do some telehealth, or send us an email or whatever. All of us here in our department are pretty easygoing and would love to help whenever we can on just about anything. I started to go through kind of the whole breadth of psychiatric issues. And again, I may not use all the right terminology. Oral manifestations, eating disorders, anxiety, psychoses, and the whole deal. And that was going to be way too long. And I'm long-winded anyway. So I cut this down to anxiety and eating disorders. I hope that's all right with you all. And then if we want to, at some point, if it's a decent talk, we can come back and talk about other issues that we'll have. And a lot of those have to do with the medications they might be taking, with some of the other disorders, and our use of epinephrine in our local anesthetics. So please stop me if you have any questions. Now let's see if I can move along here. Let's see.
Dr. Whitaker, you can let me know if you'd like the next slide and I'll advance that for you.
Oh, okay. So yeah, I'm ready. Okay. So the first thing we're going to talk about is anxiety, and y'all can of course read all this, and you know all about apprehension. And these patients, most patients don't want to come see the dentist anyway. So you take an anxious patient and you sit them, in our room. Studies have shown they only hear about 10% of what we say while they're sitting in that chair. So some of that's anxiety due to treatment. Some of it's anxiety due to payment. They don't want to hear any of this stuff, and we certainly understand that. So some people have tried to market themselves, if you will, as catering to cowards. And you'll see this if you go through the phone book, if any of y'all still have phone books, and they'll have a little ad in there that says we cater to cowards. And I thought that was always pretty cheesy, actually. You see these little stick figures or whatever, but some people, I guess, kind of like that. The other thing that always bothers me is if you look at this, there's an extracted tooth. So that's kind of our symbol. Well, that means we all failed. Okay, the tooth's sitting there on the table, and you know it should be in the mouth. And that's just kind of a funny pet peeve of mine. But you know, y'all don't show a atrophied brain on the table as your logo or something like that. So anyway, that's just a little unusual. And by the way, I'm usually joking. If something does not sound funny, it's still a joke. So okay, I'm ready for the next one. Okay, so there are obvious oral manifestations that occur with people with anxiety disorders. And a lot of these you know already. You certainly know what dental caries are, periodontal disease, and pericornitis. But some of these other ones you may or may not be familiar with. And it's something, if you're seeing a patient, they come in and they say, hey, you know, I've got this area, you know, what is it? You know, you'll probably be able to diagnose it, or at least know to refer or what have you. So pericornitis, this is something that we see with third molars, and so our wisdom teeth. And what you get if there's not room back there, you get an overgrowth of soft tissue over the distal part of the tooth. And what happens then is you have your quote normal bacteria, they get up under there, and you get a lot more anaerobes. And those, of course, are really bad actors. So they get up there and they grow like crazy. And you can get some significant pain back in there, trismus, they can't open wide, all this kind of stuff. And short-term treatment is to clean it out and irrigate it. Long-term, they usually have to have the tooth taken out. The other thing is this is called an operculum, and the tooth on top, a lot of times will chew on that, and that can get some nasty infections, unfortunately. Another thing they get are aphthous ulcers, or these are the old canker sores. We still don't know what causes the majority of these. It could be multifactorial, it probably is. We do know that stress plays a role, probably. We don't really have a way of preventing these yet, but there are some treatments, topical corticosteroids, benzocaine, stuff like that to make them feel better. The other things you can see are lichen planus, and you probably are familiar with that on the skin, the purple papules that they get in the oral cavity, some possibly related to lichen planus, and they get kind of erosive lesions on the gingiva. That's not diagnostic. There are other disorders that can look like that as well. But anyway, that's another thing to look for. And then a fourth thing would be geographic tongue. And you're probably familiar with this. If you probably have seen patients with this, maybe you have it yourself. Kids think that's really cool if they have it. Adults, not so much, because it's aesthetically, you know, not real great. But they get this kind of map-like look. Now, this is recent knowledge to me. I did not know there was any connection between geographic tongue and anxiety. I think maybe the anxiety gets worse if they do have geographic tongue. If somebody tells them, hey, your tongue is ugly, then I think that probably would increase their anxiety. Something I would tell you is, you know, in the oral cavity, squamous cell carcinoma is our number one cancer that we want to try to identify and prevent. And the high risk areas are going to be the floor of the mouth, lateral border of the tongue, and the ventral tongue, then back in the soft palate and back in there. You ever see something red on the ventral tongue or on the floor of the mouth, then you got to be a little bit worried and look twice, or certainly refer the patient. When you kind of have an out, though, is if you see something like this and you're kind of worried, but you have this serpiginous yellow border around it, then you can kind of relax a little bit. So that's something that's really helpful when we tell our dental students. So red is usually not good, but if you have other lesions down there and it looks kind of like this with that yellow border, you can relax a little bit. Another thing that's come out since COVID, we're seeing quite a bit more cracked teeth. And we actually are seeing a lot of those here in our urgent care clinic. People coming in, perfectly fine teeth, maybe a small filling, and all of a sudden they're cracked, and they have a number of different signs and symptoms that don't go along with a normal toothache necessarily. Along with that, we can have atypical pain. Glossodinia, along with that goes something you probably have faced, something called burning mouth syndrome. We see that sometimes in diabetics, and we'll see it in patients with other disorders, sometimes anemias. If we can't figure out the cause, then we usually call it idiopathic burning mouth syndrome. It can be really tough for us to treat. And sometimes we have to get you all involved to kind of help carry them through. Okay, next slide, please. Okay, so one thing we want to do with patients that are anxious is try to allay their fears a little bit. So we want to try to prevent things when they come in. And if you've been, well, some dentists really kind of do their offices up. It's kind of like a shrine, and you've probably seen that. But some of that is just to try to make it look not like a dental office. We try to get rid of all the smells that are there, you know, alcohol and the like. And so right when they walk in the door, they're not, oh my gosh, here I'm at the dentist. So we try to make it look differently. And we don't want to necessarily hide things from them, but we don't want our drill sitting right there when they walk in and our local anesthetic. It's like, wow, we're going to get you. The other thing that some dentists have done is they'll use music. Some people will use other things, you know, like candles and stuff like that, but we don't want to overdo it. Might make them nauseous. But this is just a fountain, and quite a few dentists now are using that. They'll put it near the operatory, and that running water seems to kind of help calm folks. So that's a pretty neat deal. The other thing is this actually is looking up. You can get full ceilings that look like that, or your ceiling tiles. And in our office, we took out all the ceiling lights in the ceiling, and we just put sconces on the wall. And anyway, but if you do have, you know, the fluorescent lights, you can put something like this up there so the light isn't glaring in their eyes. We certainly want to communicate effectively, and if you know, if one of us is not very good at interacting with folks, hopefully we hire people that are and can kind of put them at ease. We want to make things as pain-free as possible. You know, pain, you know, will be accentuated if the person is very nervous, and we want to try to control that. Vice versa, we want to let patients ask questions. We don't want to talk over them or assume anything. And then different relaxation techniques can be used. Hypnosis, we have a fellow that just retired here, Dr. Bob Stutchell, who was really good at this. And he was going to try to hypnotize me so I didn't eat sweets anymore, but we didn't have enough sessions. So anyway, I'm sure that's what it was. Okay, next slide, please. And I may talk too long, so you may have to cut me off at some point, and that's fine, okay? Anyway, all right. So anxiety, like we were mentioning, we want to try to prevent issues if we can. And so there are pharmacologic agents that we can use. We use oral sedation. We don't usually use it here at the dental school. In my endodontic practice, though, I used it quite a bit. We would usually use Halcyon, and we would usually just use one dose an hour beforehand. Sometimes we would use it the night before. Found that really effective. It was a little bit better than Valium. It was shorter acting, but a little bit stronger. And sometimes there are issues with Valium, and somebody that's really nervous, at least in the dental chair, young ladies especially, I think, will sometimes cry. It's kind of hard to stop that. Pardon me just a moment here. Sorry, it was my fishing buddies. I'm supposed to be out on the lake. Totally kidding, but okay. But anyway, so oral sedation, and you know, y'all, everybody gets concerned with that, and there have been cases, you know, of untoward reactions, especially in children. So they pretty much hammer it home. If we're treating children, it's a whole nother level. And we use different monitors, and, we use a pulse oximeter, limit the amount of local anesthetic and all that stuff. And people, an oral surgeon that I work with, he pretty much won't do any surgery anymore unless it's with an anesthesiologist. And in fact, he has an MD anesthesiologist that works in his practice full time. And it's great. And they have, all the setups that you would possibly need, and see a whole lot of kids. They also do it for other patients with anxiety. But anyway, in a regular dental office, for most procedures, some benzodiazepine is going to work well. Nitrous oxide is great. It's pretty safe. When a patient's having an issue, you can turn up the oxygen. They don't have to worry about any hangover, if you will. They can go right home. There aren't any restrictions to their diet beforehand. Most dentists don't use any IM sedation. If they did, they're probably gonna have a nurse that'll be doing that for them, or certainly have extra training. Although we can give COVID vaccines now, and which kind of makes sense since we're injecting every day. But anyway, it's the side effects and stuff. IV sedation, there are a lot of dentists that do this, some in their residency programs, which would include periodontists and certainly oral surgeons. Can use general anesthesia, and that certainly would not be used in a regular dental office. We do have now a specialty, it's dental anesthesiology, and these are dentists that have been to, it's just officially recognized, and I can't remember if it's 3 or 4 years after dental school. They probably won't be in doing any cardiothoracic cases or anything like that, although they could. They're trained to that level. And but they'll probably have some outside offices they'll be working with, doing third molars and stuff like that, and pediatric cases. And one day we hope to have one here. Analgesics, sometimes we'll have folks take analgesics beforehand, maybe some non-steroidals. We really don't use any codeine or hydrocodone anymore. I pretty much quit doing root canals in 2012, and we used it quite a bit back then. I think we were pretty judicious, and we didn't use it. We wouldn't give any more than a couple, 3 days if we needed to, but that certainly changed. Sometimes we will use a muscle relaxant. Patients have difficulty opening, but that also helps, I think, give us a little anxiety relief. Oh, something I wanted to mention here. Anesthesia is our big weapon. If you can get somebody numb and you said, hey, they've gotten through the shot, man, that's the big thing. And one way we do that that's kind of neat is we can do an intraosseous injection, and you drill a little bitty hole, you give them a little local and drill a little bitty hole through the gingiva, through the cortex, and you deposit the anesthetic right there. It goes right down to the end of the root of the tooth and anesthetize it. The neat thing about this type is it doesn't numb your whole jaw. And patients sometimes have an issue with that, with their jaw being completely numb. This does a great job. There are some cautions that you have to be aware of. It's almost like an intravascular injection, so you have to be prudent with using epinephrine and stuff like that. Okay, I'm ready for the next one. Okay, treatment planning modifications. So the main thing is to try to make patients comfortable. And one thing now is we're trying to get kiddies to go in to see a dentist within, right around the time that they start to have their teeth erupted. So we're talking about a year old, something like that. So 6 months on either side, and you're not going to do anything then, but just kind of introduce yourself and get the kid used to coming in there, and hopefully it's going to be a happy place. Not like before, and dentists really have changed quite a bit. We're putting a lot more emphasis now on just being, quote, nice people. You can do a great job, and nobody ever wants to come back to you if you don't treat them like they should be. And, my first feelings, I remember, were done without local anesthesia, and that kind of stays with you after a while. The other thing that can be an issue is a kid comes in and they're going to have a root canal. They're not really worried about it at all. But dad's over there and he had a root canal 5 years ago, and for whatever reason, it wasn't very comfortable. And so he's sitting back there going like, hey, Joey, this is going to hurt like, you know what? And so all of a sudden the kid's scared to death. And if the parent wasn't doing that, the kid would probably be fine. So they can be real helpful having parents in there sometimes, but not all the time. Okay, next one. I just put a couple of things here. I don't know that I mentioned, but I'm from Arkansas and just been here about 2 years, but we pretty much could be sister states. We really could. I'm from the northwest part of the state where the University of Arkansas is. It's up in the mountains, just the same kind of area. And so we really feel at home here, and hopefully are, getting along pretty well. And anyway, I just put a couple slides in here, and Arkansas is very diverse too, in that we've got mountains and areas like this, lots of lakes, lots of beautiful hardwoods. But then down in southern Arkansas, we have a ton of pine trees like you see in the deep south. And then, of course, whitewater rafting, we don't have that. We do have lots of mountains. I think we have one river that we can raft on to that extent. But then we also, down in southern Arkansas, we have bayous. We're right there in Louisiana. And so you can go in there, and there are alligators. We do have alligators in Arkansas in the southern part. Every once in a while, they'll make their way up to Little Rock, but thankfully not where we lived. And so you can get out in the lake and enjoy it. Okay, next slide. Okay, so eating disorders, and y'all are very well familiar with this, but here's some things that we have to look out for when we see somebody in the chair. And so we have to worry about hypertension. We have to worry about that anyway. If we set a patient up too fast, they may have a hypertensive episode. Bradycardia, and usually we don't, put a pulse ox on them or anything like that, and we don't have a setup like this. But if we need to, we will. We can do that in some occasions. And our oral surgeons certainly do this. And if they're doing IV sedations, we'll do that. And I guess that's AFib that we need to worry about. Excuse me, I did take ACLS at one point, but I've forgotten pretty much all of it. But the oral surgeons are very well in tune to it. There are all these issues that you have to worry about. With the arrhythmias, we do have to worry when we're giving them epinephrine. We want to make sure we aspirate. We don't want to inject right into a blood vessel. Let's see, we can probably move along on that one. Okay, oral manifestations of bulimia, and you probably or may have seen some of these. What they get due to regurgitation, they get a lot of wear, generally on the lingual surfaces of the teeth. So this is the maxilla, and we should see a lot more morphology on here as far as cusps. And these actually are premolar teeth or bicuspids. And so they pretty much have lost the palatal cusp on all these guys. So this is a cuspid tooth, a canine or what have you. And the other thing that you can see that's kind of interesting is all this kind of yellow here is actually the dentin. If you remember, that's kind of the middle part of the tooth. It's much softer than here, which is the enamel, the outer part. And once you wear through that enamel, it can go really fast because this is much softer, not nearly as dense. This is more even harder than bone. But if this goes on, then they start to wear more because they're chewing, and maybe they have a habitual bruxism. Maybe they grind. That makes everything worse. And if it keeps going, I don't know if you can see this really well, but they can erode this all the way down into the pulp where the nerve and the blood supply is. And at that point, they have to have root canals. And so anyway, we certainly don't want that to happen. It's not the end of the world, but you'd rather not to have a root canal if you don't have to. But this is the general pattern that you'd see. It's on the lingual surfaces, sometimes on the occlusal surfaces. Here's another case, and this patient, for whatever reason, they got an erosive area here, ulceration back at the junction of the hard and soft palate. They eventually kind of controlled everything, the reflux, and this went ahead and healed up. if you saw this and it was not in the face of bulimia, you'd have to be concerned about either cancer or we see some deep fungi up in there. Okay. So in anorexia, here's some changes you've probably seen, but we have the enlarged parotids, and we would call that sialadenosis. And it can occur, I think, in other glands, but that's kind of typical. And then the oral hygiene, a lot of times is going to be poor. This actually is probably a case that's much worse than you're going to run into. This is actually anug or trench mouth. And so I just put a case on here that was a little bit further along. But things you'll start to see are, you don't have the interdental papillae like you do back here. These are all punched out and necrotic, and this is caused by some spirochetes, and pretty painful, and these patients are going to be sick, probably need to be treated with antibiotics, but I probably would refer these to a dentist when you see it at this point. Okay. Ethan, do I have another 10 minutes or so? Or you want me to stop short?
Yes, absolutely. You have until 1:30. We do typically like to pause for any questions or comments so we could have some discussion, but you have until 1:30, so you're good.
Okay. Sorry, guys.
Not at all. No
Anyway,
apologies. Please.
thanks. Okay, so eating disorders, we want to try to prevent some things. And sometimes we can actually pick this up in the dental chair. So if you have a patient that has not been diagnosed before, and we notice some of these issues, like all the erosion on the lingual surface of the teeth, maybe they're starting to, to get a little full out here, we aren't going to make that diagnosis, but we can have an index of suspicion and go ahead and refer them to you all, to make that diagnosis. And then we can help you all out with as far as managing certainly their dental problems. I just put a couple of other types of erosion that are different. And so on that first one, we saw there was erosion on the palate. Okay, on these though, this is on the buccal side toward the lips. And so in this case, it's not bulimia, but this patient sucked on citrus fruits all the time. Like, I think this one was 1 lemon a day. I mean, it wasn't my patient, but so this is certainly different than on the other side. On this one, this patient had GERD. And the difference with that is sometimes it'll lie down there in the floor of the mouth and on these mandibular teeth. And instead of the whole occlusal part being gone, it wears off the tips here. And then you can just see the dentin right underneath it. And so that's a little bit different. So if you look in there, sometimes you can tell which type of erosive issue that they have. So you can see that on multiple teeth here. The interesting thing is, even though you have these defects, a lot of times they're not curious. And if you can control the GERD or what have you and need to, you can go in and possibly restore those. But it would take a bit to restore that and get something to hold permanently. Okay, next slide. Okay, treatment modifications. So we want to make sure that somebody is stable from a cardiac standpoint, obviously, and there are other cardiac issues that we have to deal with, fairly regularly. Usually it's going to be a person that's on an antihypertensive, something like that, or if they're on Coumadin, what have you. Anyway, what we want to try to do is, while they're undergoing treatment for their disease, even before that, if we can help them, is to improve their oral hygiene. And that's going to be one of the biggest things that we're going to be able to do, because while they're being treated or what have you, if it goes on a long time, or they're not compliant, then they're going to have a lot of breakdown. And so many of the patients we see here in the urgent care clinic do not place a real value on saving their teeth. And so we take out teeth on, we send them over to the oral surgery clinic, but teeth on 20, 30-year-olds are almost completely edentulous. A lot of it has to do with drugs and stuff like that, but a lot of it has to do with just not appreciating what they have as far as, or maintaining their teeth. Let's put it that way. They don't put a high value on it. Anyway, so at the start, we don't want to do a whole lot of complex treatment on these patients if they're not able to take care of it and it's very expensive, it's not going to hold up over time. So we want to get their disease under control. So what we'll do is we'll go in sometimes and we'll do like kind of a high grade, if you will, temporary material. And that's what this is. This is called an intermediate restorative material. And you can tell that's a military acronym. It's IRM. And that's great if y'all have ever had some temporary material that you had a tooth that broke and put it in there from the store. It's got zinc oxide and eugenol in it. Eugenol is oil of cloves, and it kind of atones pain a bit. And so that's a great material, really easy to use. Here's something that's much more complex. And this tooth, of course, this one is extracted, but the kids were learning on it. It requires some really intricate preparations here to get the right. Sometimes you have to use kind of a beveled edge on these. Maybe they're more rounded off and what have you. And then sometimes you have to put pins in the teeth. You can imagine how small those are, and those are to retain the filling. And then you have to decide what type of filling you're going to use. Are you going to use old silver amalgam, which still works great, but it doesn't bond to the tooth? Or are you going to use a white filling that looks great, it bonds to the tooth, but it doesn't stand up to the shear pressure? And then are you going to crown the tooth and what have you? And so at least initially, you're not going to do those. And then of course we have multiple types of crowns. We really like using gold. It's soft, which is much more like the tooth itself. It wears much better. When you get into zirconia and PFMs, if you have a tooth, like say on the top, and the bottom tooth does not have a crown on it, it can wear that down, especially if a person is bruxing. So that's something that we have to take into consideration. Okay, next. Okay, this is really interesting. I borrowed this case from Dr. Shelby Alexander, who is a prosthodontist, and that's a 3-year program after dental school. They're kind of the super dentists. They're the ones that'll take a case where a patient like needs multiple implants or they need crowns on all their teeth. Sometimes if they need an obturator, if they had a resection of the jaw, something like that, these are the folks that are going to do that. Dr. Alexander finished her program, and now she is actually misspelled something. Anyway, now she is actually director of the program here. They put out some awesome prosthodontists. They really do. And so if y'all ever need care, please think about them. So this is a case that she had while she was a resident. Okay, if you can go ahead. Okay, so this is her case. And so it's a prosthodontic rehabilitation. So this is a 34-year-old female from Fairmont. Her chief complaint, teeth are chipping and wearing away, and she'd like to have them fixed. So her history of bulimia with no known drug allergies. And the limitations were really her appointment length. She could only be there about 90 minutes total at any time. And that does make it tough for a dental student. It takes them about 90 minutes just to do a filling. And but a prosthodontist can get a whole lot done in that amount of time. But anyway, you can see all the wear that's going on through here. You can see here's some enamel, but underneath that, there should be some more opaque dentin, but it's all worn off because it's on that palatal side. Okay, next slide. Okay, so here's the patient, young lady, and pretty good picture. Head, is a little bit forward, but you have to do that sometimes to get like a good panoramic film. And you can see her smile. It's a little canted here, and we won't go into all that. But anyways, it looks like she has quite a bit of wear here. And really, I don't know, maybe y'all can see if there's some siladenosis here, but tough for me to tell. Okay. Okay, so here are her pre-treatment photographs. They do a great job of taking these. We used to have to go to classes to learn how to take film or images like this, fancy cameras and all that. And now you can just use an iPhone a lot of times. They're obviously great. So what we try to do is put the patients in centric occlusion, and that's when their condyles are seated all the way back, and you have to get them to close the best that they can. And so here's what it looked like. And you can see, like, we look at little things like, is the midline on? This one's off just a little bit. And all these things can factor in how the jaws are going to function and what have you. So right working, what this is when the patient, takes their jaw and they move their lower jaw to the right or to the left. And so what we're looking at is where the cusps are hitting. Usually want them to hit off of the canine teeth. If they're hitting all on the back teeth, then that's going to be a lot of problems. The same way when they move their jaw out, then it's the same thing. It's called a protrusive. And those are really important in how we put something back together. Okay, next slide. And here's what she looked like as far as her occlusal images. And these are really beautiful pictures. She did a great job. So the quality of the camera doesn't always make that big a difference, but how you take the film, reflecting all the tissues, using mirrors and all that, there is an art to it. So this looks very much like that other case that we saw. You can see the dent through here, and then you can see just a little edge of enamel around. She also had some carious defects in here. And this is where that dental pulp is. You can see it almost shining through here. And fortunately, it's something that if it goes on for a long time, the dentin will start to build up in the pulp. The nerve will pull back, if you will. It's kind of what happens. And so it will protect itself, and you might not have to do a root canal in those cases. On the bottom, we don't see quite the change, a little bit of smoothness in here. This is a porcelain crown, so it's not going to wear. And then we see a few of those other things like we might see with GERD. Here's a filling in here, tooth-colored filling, and you can see it's ditched out all around that. Let's see. Okay, next slide. So here's our full mouth series of radiographs. And we use multiple types of films. You may know that, but these are called periapical films. And we use those, not only look for cavities, we use them also to look to see if there are abscesses on the end of the roots. And this is a big cavity. This is the upper right, a large cavity here. You can see it again here. And we try to capture all the teeth. And these we can't see real well, but these are much darker because there's not that thick enamel on there, and so they show up more radiolucent. Then they get a little bit more radiopaque as we move around. And here was another cavity on that other side that we saw on the occlusal film. You can see down here something that's interesting. This is the lower left, is that these teeth are pretty much sheared off because in addition to the erosion, they also have some attrition just from chewing and wearing down that dentin. These films are called bite wings, and so you can see upper and lower teeth, and they're more parallel, and they can help us to tell if there are cavities in between the teeth. They can also are much better at helping us tell where the bone level is, and that's telling us whether or not there's any significant periodontal disease. Okay. So here is the diagnosis, dental class 1, and that's what you want to have. You want to have a little vertical and horizontal overlap if you can. Not everybody has that, obviously. Oral hygiene was fair. There wasn't a lot of caries or a lot of gingivitis, but there was some recurrent decay. So you can see on multiple teeth, we use a numbering system, 1 to 32 in adults. And I think it's A through T, I think, for kids, but I can't always remember those. Severe dental erosion on the palatal, the maxillary dentition, and on the occlusal, the mandibular molars, and the history of bulimia. Okay. So the first thing before Dr. Alexander went in is she started the patient on Prevident, which is sodium fluoride. There are different types, and I'm not up on all those. But anyway, suffice it to say, it's much stronger than you would have in a normal toothpaste to try to get some of this under control. Okay. So this went through multiple phases, and we try to do that with any complicated case. So the first phase was to work, with you guys to try to have the patient cease their habit. Phase 2, they really didn't do anything. And that would be a number of different things. Honestly, I can't remember exactly what they do in phase 2. So let's forget phase 2. Phase 3, so what they tried to do is use a night guard to verify the patient's tolerance of the planned opening of a vertical dimension of occlusion. And what that is, if you've seen people that have lost their teeth and they start to move their jaw forward like that, an older person, and you see that their jaws are kind of sunken in, that's their vertical dimension of occlusion. They don't have teeth holding their jaws up anymore, and so they close down more and more. So and for this lady, they're going to want to open that up a bit. But if her jaws have gotten used to that being closed, she could have issues with her musculature, TMJ pain, and all that kind of stuff. So they need to make sure that she's able to go with a little bit wider vertical dimension. Take care of the caries. And then phase 4 would be to do buildups and crowns on the teeth. And then they're going to use an occlusal guard to try to protect everything, the teeth as well as the muscles. Okay. So what they would do is they would do a diagnostic wax-up, and I think we have a picture of one here in a minute. Anyway, yeah, people's jaws, yeah, are definitely moving, and they can continue to do that over time, unfortunately. But so what this wax up, what they do is they take a tooth that look like those that are all worn, and they use they take an impression, then they wax it up on their mold to make it look like they want to, and then they can come back and they can cast everything to make it look like it should in the permanent dentition. Okay. So here's the wax up. And for a dental student, this would probably take over a semester. There's very much an art to doing this. You can't just take a block of wax and carve it all down and stick it on there, which is what I thought when I first went to dental school. There really is an art to getting the shape correct, all the contours, and it's really amazing how just a little bit of rounding here, taking an edge off there, not only can make an aesthetic difference, but can certainly make a difference in your bite. And if any of y'all ever had a grit of sand in your teeth or something like that, you can feel it. I mean, it doesn't take much for your bite to be off, but this takes a long period of time, and God love them, the prosthodontists, they get in there in the lab and they work and work and work. Thankfully, a lot of folks will have professional labs that will help them with this as well. Most prosthodontists, I would say though, they like doing this. This is something, they're gadget people. They enjoy stuff like this. As a pathologist and endodontist, I did everything I could to get out of the lab. So I like just looking at stuff and say, hey, that's what it is. And anyway, when endodontics, you're just making a hole and cleaning it out. So anyway, okay, next. So this is one thing they started with. They made an occlusal guard. So they took an impression, made a mold and all that kind of stuff. And so this is not only protecting the teeth, it's also protecting the soft tissues that we were mentioning, kind of loosening up the joint, the musculature. Okay. And so the phase 4 treatment. So the first thing, the patient, they had to commit the financial resources because, we'd love to do treatment, for free. Obviously, everybody probably would if we could, but that's a big issue. This is not an inexpensive thing. Crowns themselves are probably around, on the outside, at least $1,000 a piece. And you're talking about, probably 20 crowns in this case, maybe something like that. And the other thing is people don't realize the cost, the laboratory costs are like over $200 to get a crown back from the lab. So, it's anyway, and that's kind of passed on. And then the 90-minute time blocks in this patient. Anyway, in most cases, what they would do, a prosthodontist, they would prepare all the teeth and temporize in one day, but you really can't do that in 90 minutes. So they made their wax ups like we showed already, and they built up the occlusion, and then they prepped the teeth segmentally. Okay. And so this is a tray. They went in and they prepped all the teeth, and then they made this so she would have a nice looking temporary smile while everything was going to the lab. And so they filled this up with temporary material, and they have to really work on, these are called the margins, to make sure they don't irritate the gums too much. You don't want them big and bulky and all that. Okay. So this is how they built up the occlusal table, not only to look aesthetic, but also to see if the patient could tolerate it. And so all these little guys are markings where they have you bite down and tap, and they can tell if a tooth is hitting or not and where it is. And if it's hitting too hard or not in the right place, then they can go in and reduce that. So the bite, will be better and kind of settle in. Okay, next slide. Okay, so these are the final buildups that Dr. Alexander did. And you can imagine all the work that went into that, just completely rebuilding the anatomy. These are really fine contours. In the early days, we certainly didn't make them look quite that nice. But she did an awesome job in doing this. The cool thing is they did not have to do any root canals on these teeth, which is really surprising. Okay, next. So here are the preparations. So they go in and pretty much reduce the teeth, and they have to do it almost in every dimension. And then they have to make a really nice little margin down here. And we're talking, I don't know how much an angstrom is, but very, very small tolerance. So you'll get oral bacteria up under there, and you can get recurrent decay. And one thing that they'll do there that's interesting is you can see all of this. This is retraction cord. And in order to get a good impression, you have to place this cord down in there to displace the tissue. And you'll see some of the white areas here are due to the pressure, but a lot of this actually will have epinephrine in there too to control the bleeding, because our impressions don't turn out very well if there's blood and saliva in there. Okay. Then you take impressions. Y'all probably had those before with the goo that goes down your throat, and you have to sit there for a while. Anyway, they have much more high quality stuff when you're doing crowns and bridges and stuff like this. You use two kinds of mixes, and it's pretty incredible, very stable material that they use. Okay. So they made temporaries, and so all these guys are temporaries. Now that's a pretty incredible job. And in fact, some people will walk out and they don't even come back, not in this particular case, but in other cases, not bulimia, patients with bulimia, they'll walk out and they don't come back. And the issue is, over time, they're going to develop caries and periodontal disease, and they'll start to break down and what have you. Okay, and just some interest sake, we call that an oral melanotic macule. So it looks like a freckle under the microscope. We don't get too concerned with those. Okay. So here are temporaries, and they look pretty good to me. I'd be very happy if my smile looked like that. Okay, next. And here's the final treatment. And so these are all, I think they're all ceramic crowns. And the difference being these don't have any metal underneath them, which is used to, we couldn't use all ceramic because they didn't have the strength, but now we're able to and have a much better aesthetic result. We like using gold if we can. As we mentioned earlier, it's much softer, but very nice smile here. Okay. So here's the final, and I think the patient was obviously, I'm sure she was very, very happy with the final result. Lord willing, she's not going to relapse, and they're going to be able to, maintain these crowns with oral hygiene and all that kind of stuff. And so y'all can reinforce that too if you're seeing these patients and say, hey, have you been to the hygienist? Have you been to the dentist? You need to go check that out, because once one starts to break, it can kind of snowball. So we can sure use your help on that. Okay. The full mouth series, we can go over this pretty quickly. I guess actually, I didn't think I was lying to you, but this tooth did end up having a root canal, but that was not one of these anterior teeth here. Okay, and next. And we can skip this one. Okay, and let's skip this one and this one. Okay, this is just to show you how intricate the preparations are. And so when you go in and you prepare a tooth, you do it at 1 millimeter there, and you have little guides you prepare with your drill. You have one drill that'll do like a 1 millimeter cut. Then you take it out, do a different one that's 1.5 millimeters, and then you go back down to 1. And this is the nerve right here. So that's where the dental pulp is. So if you get a little overzealous, you can irritate or actually get into the pulp. And at that point, the tooth would need a root canal or need to come out. And you can see these are all a little bit different, 1, 1.2, 1.5. So those are very small differences, but they can make a huge, they can make a very big difference. And you want enough thickness of material there so it doesn't break down when when the patient's chewing. So it has to be thick enough. And if it's too thick, then you don't have the aesthetics that you would want to. Okay. And so again, hats off to Dr. Alexander, who did a wonderful job on this. And I certainly would be happy to have her working with my family. Okay, just have a couple more slides. This is obviously the West Virginia State Capitol. Here's Arkansas State Capitol, look somewhat the same. And anyway, this is our old main, and so looks very much like here. So anyway, beautiful states. Okay, next. Anxiolytic drugs are something that we have to be concerned with sometimes. Aggressive behavior, I'm sure y'all have seen that. Once in a while, we'll see somebody that has an issue. I don't know if y'all have seen this movie with Russell Crowe where he has road rage. Pretty good movie. It's pretty scary though. And then drug interactions, we have to worry about somebody getting too sedated. So we have to watch that in the chair. Okay, next. There are some other things that people with anxiety can get, oral conditions, something that you've seen, I'm sure, cheek biting. We call it morsicatio, and that way you can charge more when you put that name on it. And of course, I'm definitely kidding there, but it usually gets a laugh out of the patient. Cracked teeth, this tooth is pretty much a goner. There's no way to save that. And sometimes factitial injuries, patients will get in there and pick and what have you. The other thing, somebody that maybe has been somewhere they weren't supposed to go or what have you, they'll get in there and they'll brush too hard and they'll douse their mouth with hydrogen peroxide and bleach and everything. And then they come in and they're like, is there something wrong? And anyway, so they may be a little overzealous. Okay, next. Sometimes there are issues if they're taking, Tagamet or if they're taking Zantac or what have you. So we have to be careful with those. Glaucoma, we usually don't get too concerned about that. A closed angle, I think it's corticosteroids we might have an issue with. We do use benzos in our offices, but we always have the patient sign a release. We really don't use them here in the dental school, but in private practice, and they have to sign that they're not going to drive. And there are cases, at least I've heard of, where people have really had to block a door and let a patient, or not to let a patient out, or call the police. And y'all probably heard of that too. Okay, next. These are things we want to keep from happening if we can. Y'all probably have heard of nursing bottle caries. And so that's why we want to see kids when they're young, so they'll get used to going to the dentist. And also we want to educate the patient's parents. Don't give them, the bottle when they're going to bed. And so this is what we want them to end up looking like if they can. Okay, next. And guess that's all I have. It's right at 1:30. And I know we went over a lot of stuff that wasn't necessarily down to the brass tacks, but at least we looked at some things that were related to dentistry and some of the challenges we face. And so appreciate it. If y'all have things that y'all have questions about or we can help you with, please give us a call. We're always here, one of us, and a lot of us do the same things, and we'd love to help. And I hope to come back and do this maybe on another topic or two.
Thank you so much, Dr. Whitaker.
Hey, thank you for having me.
I really do hope that one day you can go fishing soon. I know
Thank you.
you've made those jokes throughout the
That's
presentation,
right.
but I do hope you can go fishing soon. We really appreciate that.
Thank you. Thank you much.
Sandra, I noticed you had unmuted. Did you have a question or comment for Dr. Whitaker?
I just thought it was great.
Oh, well, thank you. Thank you. There's a lot of stuff there, but it was fun to put together. Thank you.
Absolutely. And we got some chats and thanking you very much as well, Dr. Whitaker. So
Well,
if there are no further questions or comments right now, then we will end the session. But if you do have any after the fact, just shoot us an email and we'll make sure to send it to Dr. Whitaker so that they can be addressed.
well, thank you all for making me feel welcome.
Absolutely. And we'll always have you back. Anytime you want to come back, you're more than welcome.
Thank you much. Y'all have a good week. Bye-bye.
Thank you. Take care, Dr.
Bye-bye.
Whitaker. Bye. Only announcement I have is that our next session is on June 2nd, and Dr. Swagger will be discussing specialty conditions. So keep an eye out for that reminder. I thank you all for joining today, and we'll see you guys next time.
Bye-bye.
Bye.